Opioid addiction is a major health crisis in the United States, affecting millions and demanding long-term care. Buprenorphine is one of the most effective treatments, reducing cravings and withdrawal symptoms so people can begin recovery. Unlike heroin or fentanyl, buprenorphine only partially activates opioid receptors, stopping withdrawal without producing a strong high. Its ceiling effect makes it much safer, lowering the risk of fatal overdose. For many, buprenorphine is the first step toward rebuilding their lives. But for years, strict rules made it hard to access, especially for those in rural areas or without reliable transportation. In-person doctor visits were required, creating barriers for people who needed help the most. The system was full of roadblocks, keeping treatment out of reach. The COVID-19 pandemic forced a change. New rules allowed telemedicine, letting patients see doctors and get prescriptions by video or phone. This shift became a lifeline for thousands. But these telemedicine rules are temporary, and their future is uncertain. The journey of these rules and what comes next will shape the future of addiction treatment. The stakes are high. Access to buprenorphine can mean the difference between life and death. As we explore this story, we'll see how policy changes can open or close the door to recovery. The fight for accessible treatment is far from over. Let's look at how we got here and what's at risk if these lifelines disappear. Before COVID-19, the Ryan-Haight Act required an in-person doctor visit before prescribing buprenorphine. This rule, meant to stop illegal online pharmacies, became a major barrier for people seeking help. For those in rural or underserved areas, finding a qualified doctor could mean hours of travel, if one was available at all. Many faced challenges like unstable housing, lack of transportation, or inflexible jobs, making in-person visits nearly impossible. Stigma made walking into a clinic even harder. The rule also limited the number of doctors able to provide care, creating long waitlists. For someone in crisis, waiting weeks for an appointment could be deadly. The system prioritized control over access, treating buprenorphine with the same caution as the drugs fueling the crisis. This paradox blocked the path to recovery for many. The old rules made it incredibly difficult to get help when it was needed most. Change was desperately needed. The COVID-19 pandemic made in-person doctor visits risky, threatening access to essential care for people with opioid use disorder. In response, the government temporarily waived the in-person requirement for buprenorphine prescriptions. For the first time, doctors could prescribe this life-saving medication via telemedicine, video, or even phone calls. This shift removed long-standing barriers, letting patients connect with providers from home. The change was about more than convenience. It was about saving lives during overlapping health crises. Overdose deaths surged during the pandemic, making access to treatment even more urgent. Telemedicine became a game-changer, expanding access and keeping people in recovery. The new rules proved that a flexible, patient-centered approach was possible and effective. The pandemic forced innovation, showing that care could reach people wherever they were. The question now, will this progress last? The future of addiction treatment depends on what happens next. The stakes have never been higher. The story of telemedicine is still being written. Telemedicine rules for buprenorphine were meant to be temporary, tied to the COVID-19 emergency. But as the benefits became clear, the idea of returning to old restrictions alarmed patients and providers. Advocacy groups warned that ending telemedicine would be disastrous. The government responded with a series of extensions, first to the end of 2024, then 2025, and now through 2026. Each extension brings relief, but also frustration. The rules remain temporary, leaving everyone in limbo. Providers struggle to plan, and patients worry about losing access. The DEA says these extensions buy time to develop a permanent solution, but federal rulemaking is slow. The system is stuck in a cycle of short-term fixes. The uncertainty is exhausting for everyone involved. Patients and providers need stability, not another year of waiting. The story so far is one of delay and hope for real change. The need for a permanent solution grows more urgent with every extension. The clock is ticking. The telemedicine cliff is the looming threat if temporary rules end abruptly. Imagine hundreds of thousands suddenly cut off from their doctors and medication. The old Ryan-Haight Act would snap back, requiring in-person visits for every patient who started via telemedicine. Clinics would be overwhelmed, and many couldn't get appointments in time. For people in recovery, losing buprenorphine means withdrawal, intense cravings, and a high risk of relapse. With lowered tolerance, a single relapse could be fatal. The telemedicine cliff isn't just a bureaucratic problem, it's a public health emergency waiting to happen. That's why the government keeps extending the rules, trying to avoid disaster. The fear of this cliff is driving calls for a permanent solution. Telemedicine has become essential for a vulnerable population. The stakes are life and death. The pressure is on to build a lasting bridge, not just another temporary patch. The future of care hangs in the balance. The pandemic triggered a massive shift to telemedicine, especially for mental health and addiction care. In 2019, less than 1% of outpatient mental health visits were virtual. By 2020, it was over 46%. Even as the world reopened, about 1 in 4 mental health visits stayed online. Patients and providers found telemedicine more convenient, private, and accessible. For buprenorphine and other controlled substances, the numbers are just as striking. In 2024, over 7 million prescriptions for controlled substances were issued without a prior in-person visit, about 1 in 6. This shows how deeply telemedicine is now woven into healthcare. Millions rely on it for essential medications. The data is clear. Removing telemedicine would disrupt care for millions. The cliff is not theoretical. It's a real threat to real people. Telemedicine's growth is a sign of progress that shouldn't be undone. Patients want and need this option. The healthcare system has adapted. Now policy must catch up. The numbers tell a story of transformation. The path to a permanent telemedicine rule has been rocky. In early 2025, the DEA proposed a new rule. Doctors could prescribe a 6-month supply of buprenorphine via telehealth, no in-person visit needed. It was a compromise, more flexible than old rules, but not as open as pandemic policies. Then, a new presidential administration froze all pending regulations, including this one. The process stalled, and uncertainty returned. A government shutdown later that year made things worse, freezing Medicare payments and straining clinics. These disruptions exposed how fragile the system is. The fate of telemedicine is tied to politics and bureaucracy, not patient needs. The latest extension to 2026 offers temporary relief, but not real security. Providers and patients are left waiting. Again, the need for a stable, permanent rule is urgent. The system can't withstand endless delays. Experts, public health officials, and advocacy groups are united. Telemedicine flexibilities must become permanent. Years of data show that prescribing buprenorphine via telemedicine is safe and effective. The American Telemedicine Association and others argue that short-term extensions create instability. Providers need predictability to invest in care, and patients need peace of mind. The DEA has acknowledged the overwhelming support for permanent rules. Public pressure has kept the temporary rules alive, but it's not enough. The consensus is clear. Going back to old barriers is not an option. Telemedicine has removed obstacles and expanded access to life-saving care. Experts aren't asking for something new. They want to keep what works. The fight is for a policy that matches the reality on the ground. As 2026 begins, another extension has averted the telemedicine cliff, for now. Patients and providers have a temporary sense of stability, but the core problem remains. The DEA is expected to build on previous proposals, possibly allowing 6-month telehealth prescriptions as a starting point. What everyone wants is simple clarity and stability. A permanent rule would let providers invest in telehealth and encourage more doctors to treat addiction. For patients, it would end the anxiety of wondering if their treatment will disappear. The last few years have proven that a modern, flexible approach works. Telemedicine is a powerful tool in the fight against opioid addiction. The challenge is turning temporary success into lasting policy. Millions of lives depend on it. The hope is that the next deadline brings a permanent bridge, not another patch.